Now, it's my pleasure to introduce Professor Reddy, Professor of Hematology Oncology at Duke's Cancer Institute in USA. Professor Reddy is going to talk to us about solving the hard question in immuno-oncology, sequencing versus combination, timing, and duration.
Thank you very much. I'd like to thank the organizers, Professor Ghazali, the chairs of the session, for having the opportunity to talk at this exciting and interesting conference. So we're going to talk about, I'm a lung cancer doctor, so I'm going to talk about lung cancer immunotherapy as a way to discuss timing, duration, and sequencing versus combination therapy. I think non-small cell lung cancer is a good model because we have category level 1 efficacy data from a number of phase 3 trials. And this can be a model for looking at immune oncology, timing, duration, sequencing, and combination. So obviously we're mostly talking about a basis of treating immune therapy on the PD-1 checkpoint, where PD-1 is an important inhibitory receptor on the T cell, and when it is activated, it can block the immune response. The antibodies that are being studied are antibodies either against PD-1 or PD-L1. So first I'm going to talk about timing of immune therapy, first line and second line. So this is a phase 1 trial with nivolumab, and this was really transformational. People were surprised. The people that were doing this phase 1 study thought that it would take multiples of immune therapy, 2, 3, or more immune therapies to have a major impact on cancer. But they saw in heavily pretreated lung cancer major responses and durable responses. If you look at the survival line, this is not where we want to be, but it was an impressive survival line for patients that had had 2, 3, or 4 lines of previous chemotherapy. This led to a number of phase 3 trials, and this was the basic schema for these trials. This was Checkmate 17, but the same basic trial design was used for all the major checkpoint therapies, where patients had received previous platinum doublet therapy, had their cancer progress, and then were randomized to immune therapy versus standard second-line docetaxel chemotherapy. All of these trials were positive trials, and you're probably very familiar with their results. Checkmate 17 showed improvement for nivolumab versus docetaxel in previously treated squamous cell cancer. Checkmate 57, nivolumab improvement over docetaxel in non-squamous lung cancer. Keynote 10 showed improvement for pembrolizumab versus docetaxel in PD-L1 positive lung cancer. And OAK showed improvement for atezolizumab versus docetaxel in PD-L1 all-comer non-small cell lung cancer. On that basis, PD-1 therapy with all 3 agents was approved for second-line treatment of non-small cell lung cancer. In Keynote 10, there was a biomarker analysis done, and if you look at the top line in this forest plot, it shows the hazard ratio compared to docetaxel for tumors that stained 50% higher or higher for PD-L1. It shows a marked improvement in hazard ratio, suggesting a major benefit in this class of lung cancer that highly expresses PD-L1. This led to the Keynote 24 trial that compared standard chemotherapy to single-agent pembrolizumab. What it showed was a marked improvement in response rate for pembrolizumab in this subset, a marked improvement in progression-free survival, and an improvement in overall survival. On that basis, pembrolizumab became the standard of care for non-small cell lung cancer as first-line therapy if the tumor had a score, PD-L1 score of 50% or higher. So at the current time, for most non-small cell lung cancer, the timing is that a tumor should be tested for markers for non-squamous lung cancer, should be tested for EGFR, ALK, and ROS, and if those findings are positive, they should receive a TKI. If the EGFR, ALK, ROS, or other biomarkers are negative, then PD-L1 testing should be looked at. If PD-L1 is 50% or higher, then pembrolizumab would be appropriate. If it's negative, the patient received chemotherapy, and then consideration of immune therapy second line. So now I'm going to talk about duration of immune therapy. This was a CheckMate 153 trial, and it looked at 1 year versus nivolumab versus 2 years of nivolumab in the second line setting for non-small cell lung cancer. I thought that 6 months or 1 year of treatment would be plenty. I did not think that there would be major improvement with continuation of immune therapy. The blue line shows patients who received 1 year of treatment and then continued for a second year of nivolumab, where the red line shows patients who received 1 year of treatment and then had been randomized to stop with the option of starting nivolumab again at progression. As you can see, the hazard ratio was 0.42 for progression-free survival in favor of 2 years of treatment. I think more importantly, and this was among basically all subgroups, more importantly, there was a trend toward improved overall survival for continuation of nivolumab. So I think that this does show some justification for giving 2 years of treatment if the patient is tolerating therapy well. However, obviously this is very expensive therapy, and it could be a consideration to stop at 1 year and then retreat. Well, how about sequencing of therapy? Should we give IO, immune therapy, and chemotherapy separately or at the same time? So you're probably familiar with Keynote 21, which looked at platinum chemotherapy versus the same chemotherapy with pembrolizumab in non-squamous lung cancer. It showed a marked improvement in response rate for the combination. It showed a marked improvement in progression-free survival. And the most current data shows a trend toward improvement in overall survival. So if you look at the graph on the left-hand side, it shows that there clearly is improvement in progression-free survival. The most recent data from ESMO 2017, which is not shown here, shows a trend toward overall survival benefit. Based on this data, the US FDA approved chemotherapy and pembrolizumab for initial treatment of non-squamous lung cancer. I would say that that was a very controversial decision in the United States. I think most medical oncologists felt it was a premature approval based on a phase 2 trial without long-term results. This is the Empower 50 trial, which is a very complicated trial, but it basically shows either chemotherapy versus either chemotherapy with bevacizumab, with or without atezolizumab. It shows a significant improvement in progression-free survival for the chemotherapy, bevacizumab, and atezolizumab. It shows a trend toward early improvement in overall survival. These are the phase 3 trials that are outstanding. We just showed you the results of 150. There's CheckMate 227, which is a nivolumab trial with every possible combination you could imagine, both in the PD-L positive and the PD-L negative populations, with almost 2,000 patients randomized, and we're waiting for those results. The MYSTIC trial with durvalumab and tremelimumab, the Empower trials, and then Keynote 189, which is the phase 3 trial that compares carboplatin pemetrexed with or without pembrolizumab in advanced lung cancer. All of these trials have finished accrual, and we are anxiously awaiting the results for all of these trials. So what are my conclusions regarding where we are and what would be appropriate treatment and timing at this time? For non-squamous lung cancer, patients should have molecular testing. Clearly, if a patient has an EGFR mutation, an ALK translocation, a ROS translocation, BRAF mutation, perhaps exon 14 MET deletion, these patients should receive molecular therapy first. The molecular therapy is cost-effective, it's well-tolerated, and it's highly effective. So immune therapy has not supplanted molecular therapy for the treatment of patients with lung cancer and actionable molecular abnormalities. And that's very important and fundamental. First-line PD-L1 therapy with pembrolizumab is appropriate if the tumor score for PD-L1 is greater than equal to 50%. This is single-agent, well-tolerated therapy. The toxicity of single-agent pembrolizumab is much less than combination chemotherapy. In this setting, pembrolizumab wins on response rate, progression-free survival, and overall survival. So it is more effective and less toxic. Clearly, this has been a transformational change in cancer care and lung cancer. For almost all other non-squamous, for almost all other non-small cell lung cancer, immune therapy is an appropriate consideration for the treatment of the cancer. And that includes, in alphabetical order, atezolizumab, nivolumab, and pembrolizumab. I would also note that patients who would not be appropriate are patients with active autoimmune diseases. We don't have enough time today to go into that in great detail. However, patients who have active lupus, scleroderma, or any other systemic autoimmune disease should be given immune therapy with caution. I think that there's been a gradual movement into relatively non-systemic immune therapy, autoimmune diseases, so I think that most experts now would consider treating patients with minimal psoriasis, rheumatoid arthritis, and some other autoimmune diseases with immune therapy. I think we, as noted earlier, I think we have to think about some of the patients that we know have a low likelihood of responding to immune therapy. The consensus from the large randomized trials suggests that patients who are never smokers, and therefore the tumor probably has a low mutational burden, PD-L1 negative, and has an actionable oncogenic driver, such as EGFR, ALK, or ROS1, have a very low likelihood of responding to immune therapy. And I think in that setting, I would tend to use immune therapy third line or fourth line. Duration of treatment is a difficult issue for many reasons. One, people get tired of coming for therapy for a long time. Secondly, it is very expensive. However, we now have data from a randomized trial, a well-run randomized trial, for the subset of patients, and this is a relatively small subset of patients, who reach 1 year with good cancer control and without major immune-related side effects. For those patients, it appears that 2 years is better than 1 year. I also want to emphasize that stopping for immune-related toxicity should not be a major concern. It appears that people that have a major immune-related toxicity, this is a biomarker for the immune system being highly active. And in the setting of somebody having an immune-related toxicity, going on steroids to treat it, many patients will not progress and will have a long progression-free survival. So I always encourage patients not to be worried if we have to stop the therapy or hold the therapy for this reason. I think sequencing or combination therapy is a very difficult question at this point. Personally, I think that what I want to see before I go over to combination therapy with chemotherapy and immune therapy as routine care is I would like to see that in a group of patients who've received chemotherapy followed by immune therapy or immune therapy followed by chemotherapy, that those patients do worse than combination. So for instance, when you look at the trials of chemotherapy with or without pembrolizumab, with or without atezolizumab, I think it will be important to see a survival benefit that's long-term. I think it will be important to look at the patients who crossed over and see whether there's a difference. I'm not a researcher in the economics of oncology care, but just to get a handle, I talked to the bone marrow transplant doctors at Duke to see how much a transplant costs. And then I talked to one of our oncology pharmacists to see how much we actually got paid for patients getting triple therapy with chemotherapy plus pembrolizumab. And as best I can tell, the cost of an allogeneic bone marrow transplant is equal to about 1 year of chemotherapy plus pembrolizumab. So depending on what your dollars are and your costs are, still, that's a lot of money, no matter how you look at it. So I think we have to think about that cautiously. So I need to see a sustained benefit of overall survival compared to patients who've crossed over. So I think but we're going to have this data. So I think we have thousands and thousands of randomized patients. I think we need to see the data, and we need to see some mature data before we go all the way over to treating that. And my overall conclusion is this is just the beginning of the end for immuno-oncology. It's been very rewarding to me to be part of the initial clinical trials that have investigated this, and I'm very hopeful about the future and some of the results that we'll get for our patients. And thank you very much for your attention.
Thank
Questions?
you, Professor Reddy. And now it's time for questions. Professor Reddy, I would like to ask if there will be a role for maintenance therapy in patients responding to checkpoint inhibitors, like other non-small cell lung cancer tumors.
Excuse me?
Maintenance therapy with checkpoint inhibitors in responding patients with non-small cell lung cancer.
Yes.
Would be a valid point for these patients instead of stopping treatment after 1 or 2 years?
I would generally stop after 2 years. I've had elderly patients who are a little bit frail with multiple medical problems who got to a year, and we didn't have the data for the crossover yet, but still, after a year, we came to the conclusion that we would stop and then observe them to see if there was progression. Some of the younger patients who were doing really well and were tolerating their treatment, those patients, when you have that discussion with them, have tended to want to go on.
Okay, thank you. Any other questions, please?
Can I have a question, please?
Yeah, sure.
Yes, Professor Reddy, please. Are we relying up to this moment on the smoking history as a predictor for the response, or to omit this story?
So some of the data from the randomized trials have shown that the hazard ratio for immune checkpoint therapy compared to docetaxel is not as positive as for smokers. So the hazard ratio tends to be around 1, tends to be not necessarily in favor. This also tends to overlap with the EGFR mutation patients. And they can, in some of the data, they do worse. So
if you look at the OAK, if you go back to the OAK trial, the smoking history has not any prediction.
Right. So I would say that the OAK trial is an outlier. If you look at the nivolumab and pembrolizumab data, and if you look at all of the data, I would say that in general, patients who are never smokers, mutation positive, PDL negative, if they have all 3, then the chances of them responding are relatively low. I think the chances of them responding
to
chemotherapy
think of
is better.
other parameters like the TMB or tumor mutation burden, even in the smoking patients. I think it will be an independent factor. I think.
Yeah. So I do think that smoking is somewhat. I think that some smoking history, 5-pack years or higher, does have some association with likelihood of responding.
Very good. And coming back to the statement of 2 years is better than 1 year of immunotherapy, can I say that continuation immunotherapy till loss of clinical benefit is the standard or could be a standard?
So I think we have randomized data that now
The
supports
153,
that.
the checkmate 153, we have data.
Yes. So I think we do have data.
Yes.
I think for the treatment beyond progression that was discussed earlier, I think that I would just comment that in general, most of the patients who were treated beyond progression on the clinical trials were situations where the treating physician felt that the patient was benefiting. So that clinically the patient seemed to be doing better. Often the radiographic progression was equivocal. Like by trial criteria, it met progression, but when you looked at it, maybe it was the tumor itself, what you knew as cancer was smaller, but nearby lymph nodes had gotten bigger. And the clinician suspected that that was inflammatory, and sometimes that's ended up being granulomatous disease when some of these patients have gone to surgery. So I think treatment beyond progression is generally in the setting of the physician thinks the patient is clinically benefiting, and often the radiographic criteria are equivocal.
Thank you.
Thank you, Professor Reddy, for your interview.